Light is a form of electromagnetic radiation. At some wavelengths, it appears as visible light. At others, it takes the form of radiation we cannot see, such as ultraviolet, infrared, and X-rays. X-rays have very short wavelengths that, unlike visible light, are able to pass right through most tissues in the human body. Since bones contain calcium, a denser material than most other tissues, they are able to stop some of the X-rays and can thus form a shadow. If you place your hand in front of a flashlight, it will cast a shadow on the wall behind it. In a similar manner, X-rays directed at the body produce shadows on the opposite side that can be registered on film or on a digital sensor, so that bones are clearly visible while soft tissues, such as muscle, are shadowy. As a result, the two-dimensional images formed by the X-rays are quite useful in revealing structures within the body and can easily display fractures in bones. The heart of most ultrasound systems is a device called a transducer, which uses an array of piezoelectric crystals. A piezoelectric crystal vibrates when an electric signal is applied, producing high-frequency sound pressure waves, which we call ultrasound. More importantly, this type of crystal can also work in reverse. It can produce electrical signals when it detects high-frequency sound pressure waves. When a transducer directs ultrasound waves into the body, they pass right through the skin and into the internal anatomy. As the waves encounter tissues with different characteristics and densities, they produce echoes that reflect back to the piezoelectric crystal. This happens more than 1,000 times a second. Returning echoes are converted to electric signals, which a computer converts into points of brightness on the image, corresponding to the anatomic position and the strength of the reflecting echoes. A medical transducer contains a large array of crystals, which allow it to make a series of image lines that, together, form a complete image frame, called a sonogram. In addition, all the crystals are repeatedly activated many times in such a way that a complete image frame is formed around 20 times per second, so that real-time motion is displayed in the ultrasound image. A CT scan is an X-ray procedure that creates cross-sectional images with the help of computer processing. CT images are more detailed than conventional X-ray images and can reveal bones as well as soft tissue and organs. A conventional X-ray uses a fixed tube that sends X-rays in only one direction, while a CT scanner uses a motorized X-ray source that shoots narrow beams of X-rays as it rotates around the patient. There are special digital X-ray detectors located directly opposite the X-ray source. As the X-ray passes through the patient, they are picked up by the detectors and transmitted to a computer. Image slices can either be displayed individually in two-dimensional form or stacked together to generate a three-dimensional image that can reveal abnormal structures or help the physician plan and monitor treatments. MRIs use protons, which are abundant in the human body. All protons spin, creating a small magnetic charge. When a strong magnetic field is introduced, as is the case in an MRI machine, the protons align with that field. The MRI technician then introduces a radio frequency pulse that disrupts the proton and forces it either into a 90-degree or 180-degree realignment with the static magnetic field. Since the radio frequency pulse pushed the proton against its nature, once this pulse is turned off, the protons realign with that magnetic field, releasing electromagnetic energy along the way. The MRI is able to detect this energy and is able to differentiate various tissues based on how quickly they release energy after the pulse is turned off.
A coronary angiography, or cardiac catheterization, is an X-ray examination of the vessels and chambers of the heart, often done to identify any narrowed or clogged coronary arteries that are preventing blood from reaching the heart muscle. The study can also be used to measure the size and function of the chambers of the heart and the function of the heart valves. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you may be given an oral or intravenous sedative to help you relax. Most coronary angiography procedures last between 1 and 2 hours. Before the procedure, you will be placed on a table equipped with a fluoroscope, an X-ray imaging device. During the procedure, the fluoroscope will move around your chest in all directions to record pictures of your heart and coronary arteries from multiple angles. Most cardiac catheterizations take place through the femoral artery in the groin, but can also be done through an artery in the arm. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath that permits access to your femoral artery. Next, a soft, flexible catheter will be slipped over the wire through the sheath and threaded up to your heart. Your physician will watch the movement of the catheter on the fluoroscope. You may feel pressure as the wire and sheath are inserted, but you will not feel their movement inside your arteries. To evaluate the coronary arteries, your doctor will remove the guide wire, position the tip of the catheter just inside the arteries, one at a time, and inject a special dye. This dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with dye. You may feel flushed or slightly nauseated when the dye is injected. After sufficient images of both coronary arteries and their tributaries have been recorded, the catheter will be removed through the groin. Pressure must be applied over the femoral artery to prevent bleeding. You will then be taken to the recovery room for 30 to 60 minutes of observation, after which you will be required to lie on your back for several hours with a pressure bandage in place over your groin. You may either be discharged home on the same day or after an overnight stay in the hospital.
An upper GI endoscopy, also called an esophagogastroduodenoscopy or EGD, is a procedure that allows your doctor to view the mucosal lining of the upper portion of your gastrointestinal tract. This includes your esophagus, stomach, and duodenum. Upper endoscopy is used to evaluate symptoms of persistent upper abdominal pain, nausea, vomiting, bleeding, or difficulty swallowing. It can accurately detect inflammation, infections, tumors, ulcers, and other problems that may be present. The procedure is performed using an endoscope, which is a long, thin, flexible tube with a light and a tiny video camera attached to the end. The camera transmits an image to a monitor. Before the endoscopy, an intravenous line will be started and you will be offered pain medication and a sedative. Your blood pressure, pulse, and the oxygen level in your blood will be monitored during the procedure. Your doctor may spray your throat or have you gargle with a local anesthetic that will numb it. You will be asked to lie on your left side, and a supportive mouthpiece will be placed in your mouth. In some cases, you may be given supplemental oxygen through a nasal cannula. Uncomplicated upper endoscopies take between 10 and 20 minutes. Your doctor will gently insert the endoscope through your mouth and then slowly and carefully move it down your esophagus until it reaches your stomach. And finally, your duodenum. You should feel no pain as this is happening. Your doctor may periodically introduce a small amount of air to flatten the mucosal lining and improve visibility. If your doctor would like to collect a sample of tissue, he or she will obtain one or more biopsies through the endoscope for later examination. A biopsy will help distinguish between benign and cancerous tissues. It is also used to detect Helicobacter pylori, the bacterium that may lead to ulcers. Your doctor may also use the endoscope to treat a problem such as an actively bleeding ulcer or to stretch open a stricture or narrowing in the esophagus or stomach. After the procedure, you will be monitored until the effects of the medications have worn off. Your throat may be sore and you may feel a bit bloated. You will need to arrange for a ride home afterwards.
Hi, my name's Nick and welcome to this short lecture on the basics of the ECG. The ECG picks up the electrical activity of the heart via a series of electrodes placed on the limbs and chest. The impulses from the heart are then turned into an electrical signal and recorded on an ECG in a series of tracings, and it's going to be your job to interpret these, so let's look at some basics. When there's no electrical impulse, the ECG trace remains static on what is termed a baseline. If an impulse travels towards the electrode, it will cause a positive or upward deflection. If it is travelling away from an electrode, it will cause a negative or downward deflection. If the electrode is at an angle to the impulse, it will cause both a positive and negative deflection, as the impulse moves first towards the electrode and then away from it. ECG paper has lots of small squares on it, each one 1 mm square, and they're grouped together to make larger squares of 5 mm. A standard ECG should run at 25 mm per second, which means that each small square represents 0.04 of a second and each large square 0.2 of a second. This is important when it comes to analysing our ECG. Although the ECG is referred to as a 12-lead ECG, it only has 10 physical leads to connect to the patient. There are 4 physical limb leads which look at the heart in the vertical plane from 6 different directions. 3 limb leads look from the right arm, left foot, and the information is then combined from these leads to produce 3 further views. Leads 2, 3 and AVF look at the heart from underneath or inferior plane. Lead 1 and AVL look from the sides or lateral plane. There are 6 physical chest leads which look at the heart in the horizontal plane. V1 and 2 looks at the heart in the middle or the septum. V3 and 4 looks at the front or anterior plane of the heart. V5 and 6 looks at the side or the lateral plane. All of these tracings are then recorded on your ECG like this. The impulse starts in the SA node and depolarises throughout the atria, travelling from right to left and to the AV node via intranodal tracts. The depolarisation causes the atria to contract and fill the ventricles. This causes a relatively small deflection on the ECG termed the P wave. The impulse arrives at the AV node, which hangs onto the impulse for a short period of time to allow the atria to finish contracting and the ventricles to fill. Think of the AV node as a bit like a gatekeeper. When the AV node releases the impulse, it depolarises quickly down the left and right bundles to the Purkinje fibres, causing the ventricles to contract in an orderly fashion. The bundles in the ventricles are designed to allow quick travel of the impulse, rather like a motorway should allow fast flow of traffic. This impulse causes the much larger QRS complexes of an ECG. Because the cells have depolarised, they need to repolarise before the next impulse. Ventricular repolarisation causes the T wave on an ECG. Atrial repolarisation is hidden by the much larger QRS complexes. Upward deflections on the ECG are termed R waves. The first downward deflection before an R wave is termed the Q wave. The first downward deflection after an R wave is termed the S wave. If there is no R wave, the downward deflection is termed the QS wave, as there is no telling if it is a Q wave or an S wave. The gap between the start of the P wave and the start of the QRS complex is known as the PR interval and should take between 0.12 and 0.2 seconds or 3 to 5 small squares on the ECG. Ventricular depolarisation causes the QRS complex and should take no longer than 0.12 of a second or 3 small squares on an ECG. It's harder to find a normal for the QT interval, which is measured from the beginning of the Q wave to the end of the T wave, as it varies inversely with the heart rate. Roughly speaking, at 60 beats per minute, the interval should be between 0.35 and 0.46 seconds, but it's far more complicated than that.
Sometimes this part is more painful than the stress test.
Okay. Could you hold that for me?
Yeah.
Thank you, sir.
far, so good.
Here we go. Now have you drop your left arm down again? Your calculated maximum heart rate is 146.
Okay.
Yeah, so you went over that, so it shows as red to let us know like you went over your target. So which is good. We would actually like patients to go for as long as they can, right?
Yeah. I've never finished the stage.
Okay.
So
let's try to do your best, okay?
yeah.
Boom.
Another 10 seconds.
Another 10 seconds, okay. Work, keep it up. Oh, we stop now. What do you think? Okay, let's stop now. Alright, here we go. Keep walking until it comes to a stop, okay? Good work, sir, good work. Stay on the treadmill. Okay, I'm gonna get your blood pressure, okay? Drop your left arm down.
With each of the stage increases, you would see something because it's quite a jump in workload,
Yeah,
and the body isn't usually.
accustomed to it, right?
Yeah, exactly. But that's the purpose of
The stress test, yeah.
Yeah. It wouldn't be a stress test if it wasn't
Yeah, it's
stressful.
stressful, right? Yeah.